insurance companies. How did that happen? Your common sense tells you it happened because the insurance companies were overpaid. In Medicare's case, the so-called Medicare Advantage plans are overpaid by at least 30% or more than $100 billion a year. We must persuade Congress to terminate these overpayments. If the overpayments aren't cut, everyone's taxes will go up or services will be cut. To persuade Congress to cut the overpayments, we must be able to explain to Congress, media, and the public what's causing the overpayments. Unfortunately, there isn't just one cause. It would be so much easier if we could point to one statute Congress passed years ago that ordered CMS, the Centers for Medicare and Medicaid Services, to pay Medicare Advantage plans 30% more than necessary. But that's not how it happened. It happened because Congress enacted 3 laws with little forethought and then did nothing for years as it became apparent the laws had authorized huge overpayments to the insurance companies. First of these laws was enacted in 1972. It inserted HMOs into the Medicare program. The second law was the Balanced Budget Act of 1997, and the third was the Affordable Care Act of 2010. The simplest way to explain how these overpayments happen is to give you a short history of the evolution of the overpayments. And I'll divide this history into 3 parts. Between 1972 and 2004, there was only one cause, and I'm going to speak in this training of only 4 causes. But the report that PNHP will put out will talk about 5, and I'll save discussion for the 5th one until the question and answer session. It's a little complex. I just want to make sure we get through these first 4. So between 72 and 2004, there was one cause. Between 2004 and 2012, there were 2 causes. And since 2012, there are 4 causes. Between 1972 and 2004, insurance companies were overpaid because they enrolled unusually healthy seniors, but they were paid as if they enrolled seniors in average health. The phenomena of the Medicare insurance companies enrolling healthier people is called favorable selection. So a quick example that I'll use several times of how favorable selection leads to overpayment. Imagine that the average cost of insuring a traditional Medicare beneficiary is $10,000 a year. That's close, but let's make the math easy. Imagine that Humana, at the end of this year, enrolls Medicare beneficiaries who, on average, would have cost CMS $9,000 if they'd stayed in the traditional Medicare program. So ideally, CMS should ratchet the premium down to $9,000. If CMS can't or won't do that, that will result in a $1,000 overpayment simply due to favorable selection. And Humana will run to the bank with that extra $1,000 per beneficiary. Now, over the decades, CMS made a feeble effort to adjust the premium payments to the Medicare Advantage plans downward to reflect the superior health status of enrollees. That process of adjusting premiums downward to match health status is called risk adjustment. For years, the risk adjuster that CMS used relied solely on age and sex. Somewhere in there, they added Medicaid eligibility. It didn't make much difference. I'm going to refer to the risk adjuster components as mainly age and sex until the early 2000s. That risk adjuster could only explain 1% of the variation in spending between Medicare beneficiaries. And I'm going to explain that concept, predicting the variation in spending, 2 different ways for you. Here's the first way. Let's go back to our Humana example. They've enrolled people that ought to cost them $9,000. We need a risk adjuster that eliminates that ratchets the premium down to $9,000. Unfortunately, a risk adjuster that can only predict or explain 1% of the variation claws back only $10, only 1% of that $1,000 overpayment. That's how bad a risk adjuster that can only predict 1% of the variation is. And I'll give you another illustration when we get to the slides. We estimate in this upcoming report that favorable selection is currently adding 11 to 14% to the overpayments. And when I say overpayment, I mean a payment to the Medicare Advantage plans that exceeds what CMS would have paid for those enrollees had they stayed in traditional Medicare. Between 2004 and 2012, there were two causes of overpayments. Favorable selection continued to be one. And along came something called upcoding. Upcoding is defined as either adding somebody, the doctors, the insurance companies, somebody working for the insurance companies, adding diagnoses to patient medical records that are false. Patient doesn't have cancer, but there's cancer on the patient's medical record. Or it's accurate, but it's irrelevant to the treatment for which Medicare Advantage plan and ultimately CMS is being billed. Both forms of upcoding make the patient look sicker. And since 2004, it has been beneficial to the Medicare Advantage plans to make their patients look sicker, their enrollees. Here's how it happened. In 1997, Balanced Budget Act, a law enacted by Congress, ordered CMS, Centers for Medicare and Medicaid Services, it had a different name back then, to add diagnoses to the age and sex factors. And you can see the logic of that. Once you've been diagnosed with diabetes, you can predict quite confidently that now that patient is going to cost more next year than that patient would have cost when that patient only, you were adjusting only for age or sex. Adding these 3,000 diagnoses, that's what CMS did, and they rolled out the new risk adjuster between 2004 and 2006. So this new diagnosis-based risk adjuster made a slight improvement in accuracy. It went from 1% to 12%. Not much to write home about. And again, to go back to our Humana example, what that means is that Humana's overpayment of $1,000 would now be reduced by $120. That's better than 10, but it still left Humana with an enormous profit it never earned. The problem is that this tiny little increase in accuracy in the risk adjuster gave the insurance companies a new way to cheat. It's called upcoding. The insurance industry, and we'll get into some examples in the slides, and you may have heard the news that Cigna just cut a deal, just signed an agreement with the Department of Justice. I forget what the penalty was. I think 170 million for upcoding. So DOJ is trying to sue them, and Congress has played whack-a-mole with the insurance companies since the diagnosis-based risk adjuster was implemented. They authorized CMS to reduce Medicare Advantage plan payments across the board by 3%, then 5%, then 6%. It's never enough. They are always ahead of Congress. The current estimate by MedPAC, the commission that advises Congress on all things having to do with Medicare, their current estimate is that upcoding adds 5% to the overpayments. Since 2012, there have been 4 causes of overpayments. Favorable selection continues to be a serious issue. Upcoding is a serious problem. And now we have a bonus that insurance companies earn if they score 4 stars on CMS's flimsy little meaningless 5-star quality report card for Medicare Advantage plans. And you'll see a slide indicating that even MedPAC, who loves Medicare Advantage, is calling for the repeal of this report card. It's worthless. And now we're adding to the overpayments by giving Medicare Advantage plans bonuses for getting 4 stars on it. And the other bonus, and both of these were created by the Affordable Care Act, is a bonus for those insurance companies that sell insurance in less populated areas of America, where fee-for-service costs, the traditional cost of insuring Medicare beneficiaries, are a little bit low. I'm not quite sure what the reasons are for the lower cost. I think it's just lower cost of living. But somehow Congress persuaded, oh, we want more Medicare beneficiaries in these more rural areas in Medicare Advantage companies. So what we're going to do, we're going to give them a bonus for going into these less populated counties. I'm going to refer to that as the county bonus. Now, let me bring up some slides and go back over some of this same territory with a little more detail. Get my marker up here. Okie doke. First, some definitions. You all know what Medicare Advantage means. I don't think I need to define capitation for this crowd. Basically, it's the anti-fee-for-service method of payment. It's a payment to an insurance company, doctor, hospital clinic chain that is per enrollee, per patient. It encourages whoever is being paid that way to order fewer services. When the term is applied to the insurance company level, it's synonymous with premium. Beats the heck out of me why we talk about capitation payments to insurance companies, but somehow that usage has developed. Fee for service simply means paying for services as they are rendered. You will often see in the literature that the traditional Medicare program, the part of the program that is not Medicare Advantage, is often referred to as fee for service Medicare. CMS is the agency that runs Medicare and Medicaid, and I've already defined the Medicare Payment Advisory Commission for you. Here are the three laws that led to the overpayments that we're going to report are totaling 31 to 35%. We're going to offer a smaller number, around 25%, to describe the four factors I've just described to you. If we bring in the fifth factor, which we're calling induced utilization, we will get to 31 to 35%. The first law in question here are the Social Security Amendments of 1972. They inserted HMOs into Medicare, and Congress did nothing resembling due diligence. They never anticipated how we would have to figure out whether HMOs would enjoy favorable selection. If they did, what to do about it. Balanced Budget Act of 1997 was the second law that aggravated the problem. This is the law in which Congress said to CMS, your little age and sex-based risk adjuster is pathetic. We've been warned 100 times by the USGAO and other experts that we're overpaying the HMOs. HMOs, by the way, were the only type of insurer that could participate in Medicare up until 1997. The VBA changed that. And so Congress said, CMS, you need to improve the risk adjuster. We're hereby ordering you to start using diagnoses. And CMS responded by rolling out the new diagnosis-based risk adjuster between 2004 and 2006. The Affordable Care Act is the third culprit here. They raised overpayments even more, as if favorable selection and upcoding weren't big enough bonuses for the insurance companies. Congress said, let's give them more through the quality bonus and the county bonuses. So here's the total damage. You see, we're estimating favorable selection coupled with bad risk adjustment to add somewhere between 11 to 14%, and that's because the studies on this issue vary a little bit. Upcoding, according to MedPAC, is another 5%, and again, this is in excess of the deflators that CMS is authorized to use. The quality and county bonuses add another 6 or 7%. And this induced utilization factor adds 9%. The PNHP Policy Committee considered listing a sixth factor for favorable deselection. As I think you all know, every year a certain percent of Medicare beneficiaries who are enrolled in Medicare Advantage plans disenroll. They go back to traditional Medicare. And you won't be surprised to know that those who disenroll are much sicker than those who stay behind with their insurance company. And so when they go back to the traditional Medicare program, they drive up traditional Medicare program costs and they lower Medicare Advantage costs. We couldn't find any recent research to tell us how big this is. And so we just, for the sake of our own credibility, we listed nothing. This slide shows you what a bonanza Medicare is these days for the American insurance industry. You see that the insurance industry makes far more money per enrollee off of Medicare Advantage than it does off of these other markets. Is that not obscene? This is Medicare, the program that was created because the insurance industry didn't want the elderly, and now it's their golden goose. Because Medicare is the golden goose for the insurance industry, they have an enormous amount of money now to pay for services that Congress will not allow the traditional Medicare program to cover, and that is inducing many people, for perfectly good, sound financial reasons, to sign up with Medicare Advantage. They don't know, most, perhaps all, Medicare Advantage enrollees are probably unaware of Medicare Advantage's bad track record of denying services, but unquestionably, it can be a financial boost for people who can't afford supplemental coverage. Now, I want to talk about this first factor for a few slides. Take a good look at this excerpt from a 1996 report by the Physician Payment Review Commission. It was replaced a year later by MedPAC. It was one of numerous reports that Congress received in the last 2 decades of the last century, warning Congress that you are vastly overpaying, at that time, the HMOs that are participating in Medicare. And you see they comment both on favorable selection and favorable deselection. The favorable selection they found was on the order of 37%. Back in the data examined was for 1989 through 94. So back at that time, before the HMOs had really taken over a lot of Medicare, favorable selection was essentially giving them a 37% boost. But the report went on to say that beneficiaries who stayed with their HMO had the lowest relative pre-enrollment expenditures of all the enrollee groups, with total spending averaging only about 56%. So if you take 56% from 63%, you get a 7% difference. That 7% is probably a good measure of the benefit of favorable deselection. Now, this is just way too old to rely on today. It's the only study I'm aware of that allows us to say at one point, favorable deselection coupled with bad risk adjustment added substantially to the overpayments. We don't need to tarry long here. I just want you to know these are samples of reports that Congress received over the decades saying the same thing over and over and over. You are overpaying the HMOs. 1995, 2005, same message. Title of the report was, payments exceed cost of fee-for-service benefits, adding billions to spending. It is largely excess payments, not managed care efficiencies, that enable plans to attract beneficiaries. Here is a recent estimate of the benefit Medicare Advantage plans get from favorable selection. It was using 2016 data. This is by the Kaiser Family Foundation. What you see in this left bar is the average cost in 2016 of insuring a traditional Medicare beneficiary is a little over $9,000. You see here in the blue bar on the right, average cost of insuring Medicare beneficiaries who switched Medicare Advantage plans that year is a little over $8,000, and the difference was about 13%. So that 13% number is right smack in the middle of the 11 to 14% range that we're using in the upcoming study. Here's just a brutal assessment by MedPAC. And as I said, these people love Medicare Advantage, but they do find the courage to tell Congress Medicare Advantage plan was supposed to lower cost. Private plans in the aggregate have never produced savings for Medicare. You can't get more blunt than that. And note the date, it was just a year ago. Let's see, this is just illustrating the math that I already walked you through. If the cost of insuring a Medicare beneficiary. The traditional program is $10,000 a year. Humana enrolls beneficiaries, cost $9,000 if they'd stayed in the traditional Medicare program. Humana will be overpaid by $1,000. A really good risk adjuster would reduce the premiums by $1,000 to $9,000, and there'd be no overpayment. But that's not the world we live in. For decades, up until 2004, actually, CMS began to phase in diagnoses in 2000, but it occurred rapidly between 2004 and 2006. So I'm going to keep saying 2004 was the year diagnosis-based risk adjuster was implemented by CMS. But until then, the risk adjuster using age and sex could only predict 1% of the variation in spending. And because it could only do that, it could only claw back $10 of the $1,000 overpayment. And Humana went to the bank with $990. Now here's another way to explain how bad a 1% risk adjuster is. This chart divides Medicare beneficiaries into quintiles, into fifths. So here's the healthiest fifth in this bar graph. Here's the next healthiest here. Way over here, we have the sickest 1%. The 1% risk adjuster overpaid for the healthiest 20% by 166%. CMS would have owed Humana $1 for the patient, and CMS paid them $2.66. And conversely, over here, CMS would have owed Humana $1 for the sickest 1%, and they paid them only 17 cents. Capitation or premium payment, even if it's perfect, creates an incentive to deny services to patients. This is brutal. And now you know what happened. Congress said, this is not tolerable. CMS start using diagnoses. And that led to the new method of cheating called upcoding. The new diagnosis-based risk adjuster, as I said earlier, had a 12% accuracy. It could reduce the $1,000 overpayment by a mere 120. Not a whole lot to write home about. I'm fairly confident that this slight reduction in the overpayments to Medicare Advantage plans because of increased accuracy was more than offset by the riches gained by upcoding. I'm looking forward to a study on that. All right, so now we come back to this same graph and ask, well, how bad is a 12% risk adjuster? Here again, you see the healthiest 20%, and you see that now they are overpaid only, quote unquote, by 62%. That's better than 166%, but that's still pretty lousy. And if you go all the way over here to the sickest 1%, a 12% risk adjuster now pays Humana 71 cents on the dollar. And that's a whole lot better than 17 cents, but it's still lousy. And it gives the insurance companies a huge incentive to avoid the sick and to deny them services when they can't avoid it. Here's the definition of upcoding. Diagnosis is false or irrelevant to the treatment. Now here is an example of how upcoding is done by one very well-known Medicare Advantage insurance company. This is an excerpt from an article in Modern Healthcare about Department of Justice's suit against Kaiser. And it reports that Kaiser coerced employees into upcoding, and that resulted in a 75% error rate. More than half of Kaiser physicians said they were forced to add diagnoses. They did not evaluate or treat. Kaiser would orchestrate coding parties where physicians would sit around and list diagnoses with lists of diagnoses and add them to the patient visit records. Each diagnosis was worth approximately $3,000 to Kaiser. I don't think this suit has gone to trial or there has been any settlement. But as I said earlier, Cigna just settled a similar suit. Now, to give you some idea of how upcoding just exploded after the new diagnosis-based risk adjuster was phased in, take a look at this chart. This is from MedPAC. I'm not quite sure why we don't see any evidence of upcoding in 2007, because the risk adjuster, the new diagnosis-based risk adjuster, was completely phased in by 2006. Maybe it just took them a while to figure out how to cheat. Then you see these bars show you the entire increase in overpayments due to upcoding. The blue portions of these bars show you how CMS used its authority from Congress to deflate the overpayments, but you can see that the blue bars never take over the entire bar. And to take 2021 as an example, you can see that the insurance companies raised their payments by 10.8% simply by upcoding, and CMS reduced the payments across the board by a mere 5.9% for a difference of 5%. This chart shows you what upcoding and the diagnosis-based risk adjuster facilitated. You see here that this is total enrollment in Medicare Advantage plans between 1999 and 2019. If we could get this out to today, it'd be closer to 50% of all Medicare beneficiaries. But look, when the increase, what happened with the increase, you can see that enrollment was starting to decline in the early 2000s. Now they phase in the diagnosis-based risk adjuster. All right, it's the end of 2006. Kawoom! Enrollment skyrockets. I have not seen a study that says this, but I think it's reasonable to conclude that this rapid increase in enrollment was due to the insurance industry's ability to offer many more services that traditional Medicare could not, and they could finance it from the new riches gifted to them by the new diagnosis-based risk adjuster, by upcoding. I guess I'll close here. Just to let, this quote is from MedPAC, from the transcript of their January 2023 meeting. You can see here that the staff is saying the commission has concluded quality cannot be meaningfully assessed through CMS's current Silly 5-star program and should not be used to distribute bonus payments. Bonus payments now account for $15 billion. That's probably 4% if you do the math. Well, let's come back to this slide if you're curious about the county bonus system. But essentially, the big numbers you want to see are Congress authorized CMS to pay 15% above the national average for the more rural counties, for the 25% least costly fee-for-service counties, all mostly rural, and then to raise by 7.5% for the second quartile. And again, there was no reason to do that, but they did. So once again, here's the total damage. Favorable selection, 11 to 14%, upcoding 5%, quality bonus is 4%, county bonus is 2 to 3%. And if we do add up induced utilization, total comes to 9%. My guess is, now as you think ahead, we need Congress to address all or at least some of these. I have the feeling that if Congress would simply repeal the quality and county bonuses, that would drive a lot of insurance companies out of Medicare. And if they were really cracking down on upcoding, that might do the trick. And if they were to address induced utilization, I'm sure it would. I doubt we'll ever fix the favorable selection bad risk adjustment problem. We'll get into why that is later. And that's my show for tonight.
Thank you so much, Mr. Sullivan.
I have a quick question. The favorable selection. Maybe I missed that part, but what is the favorable selection and bad risk adjustment? Sorry.
Yeah, I explained that in my opening statement. I'll do it again. Favorable selection is the term we use to describe the phenomenon of the insurance companies in Medicare enrolling patients in Medicare beneficiaries who are in above average health. And the examples I was giving was, let's say traditional Medicare's cost is $10,000 a year for those beneficiaries. At the end of, say, 2023, Humana enrolls beneficiaries who on average would have cost CMS $9,000 had they stayed in traditional Medicare. If CMS pays $10,000 for patients who only cost $9,000, that would amount to a huge overpayment of $1,000. That would not be a problem if risk adjustment, adjusting premiums downward to reflect the superior health status of Medicare Advantage enrollees, were accurate. It is woefully inaccurate, and so it permits risk adjustment to be a serious cause of overpayments.
All right, another question that we've got from the chat. What is induced utilization?
Okay. You understand now that the payments to Medicare Advantage plans are based on the average cost that Medicare incurs to insure the traditional Medicare beneficiaries. And I've been using the number 10,000 in my examples. And that 10,000 covers the utilization of all Medicare Part A and Part B services. But a portion of the services that are demanded by traditional Medicare beneficiaries is not paid for by CMS. It's paid for by supplemental insurance. And who pays for the supplemental insurance premiums? It's not CMS. It's not the American taxpayer. It's the traditional Medicare beneficiaries who fork out big chunks of money to be able to afford the services that would otherwise not be covered. We borrowed the term induced utilization from Don Berwick and Rick Gilfillan. They wrote a very influential series of articles for Health Affairs on the overpayments to Medicare Advantage plans. Induced utilization is probably not the right word because it suggests that the services people buy, if they have supplemental coverage, is unnecessary. It's frivolous. They wouldn't really have asked for the services if they didn't have supplemental coverage. But for lack of a better phrase, that's the phrase we're using, is induced utilization.
So is this like if a patient, is this like, for example, if a patient has sleep apnea and let's say under Medicare, they're covered for for the visit with the pulmonologist for the sleep study, then the CPAP machine, let's say like that, would that be an example of induced utilization? So now the patient has to pay out of their own pocket.
Yes, and it could be much bigger than that. As you know, traditional Medicare without supplemental coverage has some big holes in it, big deductibles, big out-of-pocket payments. So the threat of incurring a big out-of-pocket payment could itself deter you from going to the hospital with appendicitis, say, or a heart attack. But yes, I believe that's an example. So everybody really ought to have supplemental coverage if you're in Medicare, because of the holes that you're exposed, the exposure you undertake if you enroll in Medicare and you don't have either Medicare Advantage or supplemental coverage. So if everybody's with me so far, get that supplemental coverage encourages people to actually get the care they need when they need it, and not to deny themselves because of the fear of a big out-of-pocket payment or whatever. And the data says that. The data is very clear. People who have supplemental coverage use more services than people who don't. But the problem basically is CMS is not financing the supplemental coverage. And so if CMS uses average expenditures on traditional Medicare patients as the standard with which to decide how much to pay Medicare Advantage plans, well, essentially what they're doing is saying, we're going to give a gift to all the people who enroll in Medicare Advantage that the poor schmucks that are staying behind in traditional Medicare don't get. And so that if
the Medicare Advantage plans won't even accept those poor schmucks.
Well, they don't have a choice, but they do have a choice in getting rid of them. Um, so anyway, I hope my explanations has made it clear why the PNHP report is going to list induced utilization as another factor. It amounts to an overpayment to the Medicare Advantage plans of 9%. Now, I'm happy to take questions on that because, as I said, I tend to avoid it because I think the first four factors I described to you are complex enough and don't want to overwhelm you. I mean, the right thing to do, if you just imagine you are Congress and you're about to insert HMOs into Medicare, you should have stopped and scratched your head and thought for a minute. Now, wait a minute. Are we going to ask CMS to use average expenditures on traditional Medicare patients as the standard with which to determine how much to pay Medicare Advantage plans? Or should we ask them to use how much they would have spent on those Medicare beneficiaries if none of them had supplemental coverage? That's what we're saying. We're saying the proper benchmark would have been expenditures on traditional Medicare beneficiaries if none of them had supplemental coverage. That would have been the good yardstick for Congress to use in measuring the performance of Medicare Advantage. Because the goal was Medicare Advantage was inserting HMOs into Medicare was supposed to save money. Well, if you're going to save money, you've got to get below the expenditures that CMS would have incurred for traditional Medicare beneficiaries if none of them had supplemental coverage. And it's odd that, where are we, 50 years go by, or for 40 years, we got that from Rick Gilfillan and Don Berwick. When I saw it in their article, I went, geez, that's right. Why has nobody talked about this before?
Another question from the chat, is favorable selection basically favorable deselection, i.e. kicking out people with average or below average health?
Could you repeat the question?
Is favorable selection basically favorable deselection?
Well, they have the same effect. They lead to overpayments to Medicare Advantage plans. But it's useful to have two different terms because if you wanted to stop favorable selection, you got to do one thing. If you want to stop favorable deselection, you got to do something else. So it's useful to.
Well, you said that the Medicare Advantage plans, like, they can't choose who they accept, right? But I thought favorable selection was like favorably selecting people who are healthier.
A good question, and that's another phrase. I wish we had another label for it. Favorable selection does imply that the actor causing the favorable selection is the insurance industry. They don't have that much control. There are things they can do. They can advertise in certain ways. They can recruit in healthier neighborhoods. They can avoid doctors who have clinics in poor neighborhoods with lots of drug addicts. There's a lot they can do on their end to induce favorable selection. But I believe the main cause of favorable selection is the behavior of beneficiaries themselves. Sicker beneficiaries are just less likely to want to give up a choice of provider in exchange for vision coverage and hearing aid coverage. And that's why I said earlier, I think fixing favorable selection, we'll never be able to do it completely. And since accurate risk adjustment is totally out of the question, that's a problem we can swing at forever. We're probably never going to solve. We'll get rid of it when we get rid of the Medicare Advantage program.
So how do we go about like improving this? Because clearly, I don't imagine this is beneficial for the government. So having these Medicare Advantage plans, they're overpaying them, and they weren't doing such a good job. They weren't doing such a good job before Medicare Advantage plans either. So like, I mean, I would imagine that the solution would be somebody saying, "Hey, these are the ways in which we should assess risk adjustment. These are the ways in which we should, pay out to beneficiaries, and these will save money in the long term. Um, how do we even go about affecting that change?
Good question. Here's the first decision. I think I'm speaking for the PNHP Policy Committee accurately when I say this. Kay, correct me if I'm wrong. We decided that the first step is not just to go to Congress and say, get rid of the Medicare Advantage program. That probably will never work. But we do think many, perhaps most members of Congress will respond favorably to the argument that we should not be overpaying them. They were a demonstration project. And so let's examine the ways they're overpaid. And we want you then to engage in a discussion with us about how to stop the overpayments. Unfortunately, I think that, fortunately or unfortunately, a good faith discussion of what it will take to eliminate all four of those causes and induce selection, induce utilization, will lead you to say, this may get us into an infinite game of whack-a-mole. I think we can say to Congress, just start the process. Repeal the quality bonus, repeal the county bonus, and address, let's say, the induced utilization factor. Cut the benchmarks. And now let's see what happens. That way you can't be accused of terminating the precious Medicare Advantage programs. And at the same time that you do that, introduce legislation to add vision, dental coverage, and other services that are not covered by traditional Medicare now, so that when people are forced out of Medicare Advantage, they can return to a much better traditional Medicare program. But this is the first step. We've got to get the conversation going on the total size of the overpayment. I think jaws drop when they see that we're spending $100 billion more. We spend $400 to $450 billion a year on these bloated, inefficient, unkind insurance companies. And to discover that that's way more than we would have spent if people had never left traditional Medicare. I think even people that believe in free markets are going to say, no, that's not acceptable.
Yeah.
Another question we've got from the chat is the overall policy recommendation to advocate for a single payer system or incremental reforms?
Nothing's changed. We need single payer. But, and again, Kay, correct me if you think I'm wrong, but I think all of us, I'm the people, Healthcare for All Minnesota PNHP chapter, and the PNHP board, we're deciding we've been asleep at the wheel for too long on the total takeover of Medicare by the insurance industry. We have for years assumed that a imperfect single payer known as Medicare would be there for us to point to. Wouldn't have to point to Taiwan or Canada. Here is a homegrown single payer system. And we could say Medicare for all, and people would have a rough idea of what we mean. Now it's questionable whether you want to say Medicare for all, because now we've got the insurance industry taking it over. So we see that reversing the privatization of Medicare is a boost to the single payer system, to the single payer legislation we're fighting for, both because it allows us to go back to referring to Medicare as the American grown single payer system that we want to improve, and to weaken our opponent. We are enriching our enemy by the hour, and have done nothing about it until recently. Yes, so the Jayapal bill, the Bernie Sanders bill, they're still on the flagpole. They're part of the presentations we're making all over the country.
Do we have any other questions before we move on? All right. So I'm going to drop 2 links in the chat. The first one is a guide to writing an op-ed. And then the second one gives you a link to signing a petition. And I'm also going to share my screen right now. Okay, so we've got a couple of action items for tonight. We'd like everyone to take some time to sign this petition and send it to a couple people that you know, whether that's people in your SNaHP chapter or just friends and family, anyone that would also agree with the petition to protect Medicare. And then the other, the op-ed writing guide, please take some time to look over that. A great activity to do with your SNaHP chapter would be to host an op-ed writing party, where you all get together and write an op-ed about Medicare and submit it to any local newspapers. And Mr. Sullivan, if you have any time, could you tell us a little bit about why writing op-eds is important?
The media has ignored, until just recently, the media has ignored the corporate takeover of medicine in the entire country. Fortunately, that has changed. We're beginning to see more articles about particularly private equity. And to some extent, hospital clinic chains are buying up more and more physicians. But we've seen very little on the reason why Medicare Advantage plans are taking over Medicare. It's a way of alerting the public. It's a way of alerting policymakers. And once it gets into newspapers, it's a way of alerting editors and reporters. This is a story that you guys need to be paying attention to. I think both the fairness issue and the amount of dollars that are at stake here should get the attention of any editor running a newspaper.
I have a question as well about, so this is just Medicare and how it's being sort of privatized through Medicare Advantage, but also then you have like companies like, for example, Optum. So it's a subsidiary, I think, of United Healthcare. So it is an insurance company, and now that insurance company is buying up physician groups, and so I mean, it just seems to me like something out of something that should have been covered with antitrust laws or something, because you have an insurance company employing physicians who are then billing their own employer. So who is that going to serve? I mean, if you said that to anybody, they would probably be shocked. But this is somehow happening unabashedly in our country.
This report that we're about to put out, and op-eds that you guys might write, they will tell one chapter in a longer saga about the corporate takeover of America's medical system. And what I'm eager to see is that somebody puts all these chapters together and traces the beginning, it traces it back to the destruction of an old common law principle called the prohibition on the corporate practice of medicine. I don't think there was a lot of federal or state legislation establishing that principle. I think it was mainly created by the courts, to some degree, opinions by attorneys general. But that prohibition on the corporate practice of medicine was first assaulted by HMO advocates. Here in Minnesota, to give you an example, we passed a law, our esteemed legislature passed a law in 1973 exempting HMOs from the corporate practice of medicine. Um, there was common sense behind that prohibition. Doctors go to medical school. They then take exams, and then they're licensed, and they're subject to all kinds of regulations. The reason we do that is that healthcare has to be good. People's lives and their health is sacred. And we don't want some friggin' MBA who knows nothing about it being able to interfere in the doctor's decision making. So I'm giving you a long-winded answer to your observation about Optum buying up physicians. We don't have time, but maybe we should schedule another long discussion about how it is that doctors are now in the position to feel they're better off accepting an offer from a big corporation like Optum than setting up shop on their own. There are reasons for that, and it goes back to the race to gigantism, the benefits given to enormous size that was unleashed by the fascination with HMOs at the federal and state level. I realize I'm trying to summarize a long, sad story in a few words, but that's the thought that your comment triggered.
And on that kind of note, like, I just learned today that Japan has some of the largest life expectancy and healthiest population. A lot of their physicians or offices are, it's not corporatized at all. Essentially, it's like family clinics or like small groups of physicians. And so I don't know, this is something I've always thought. So I was curious as to your guys' thoughts on this, is that perhaps one of the solutions to this is, obviously we could kick the bucket up to Congress and everything, but I think another solution is that as medical students become residents and then go into their clinical practice, instead of just sort of changing the system from within, like if you have, let's say 5 of us opened a clinic, well, and we had this goal of that we're going to structure our pay and our business model in a way that is better than what we're seeing everywhere else, like whether it's some combination of like stratified concierge model or something like that. I wonder if something could be done at that level.
Well, I wish you well, but I think all of you entering the physician labor force now are you're dealing with enormous economic forces that didn't exist 40 years ago, maybe even 15 years ago. Boy, the entry of private equity into the maelstrom is scary. I mean, we didn't see Amazon and numerous private equity firms rolling up, as they say, anesthesiologists and dermatologists as we do now. But I mean, good luck. My wife's primary care doctor is in her 40s. She just told her she's leaving. She's going to go to Puerto Rico and work with drug addicts. She's had it. Breaks my heart. She helped unionize. She's leading a fight to create a union here in the Twin Cities, a union of doctors. If they succeed, the vote's coming up in a couple of weeks. It'll be the largest physician union. And that's how dedicated this woman is to justice and her patients. And she's leaving. I don't mean to sound that gloomy, and I just mean to say we need political action. And if people can do things individually, God bless you. But we need political. We need organizing as well.
All right. Thank you so much, everyone, for joining us today, and thank you, Mr. Sullivan, for a very engaging presentation. We'll send out an email after this with a link to the recording, as well as links to the op-ed guide and the slideshow that we've shared so far. And we'll also send contact information for Mr. Sullivan if any of y'all have any further questions. But thank you so much for coming out.
Feel free to ask them, and thank all of you for doing what you do.